He's got a diplomate in neurology. He's got a wonderful practice in St. Augustine. So many things that he's going to talk to you about. Some of the stuff I even mentioned in class, so it'll be a really cool way of kind of tying some stuff into movement science. Ask questions. Don't be afraid to do that. Have some fun. This will break up a little bit of the monotony of all the class stuff. And then we will continue on with all of our stuff on lecture on Monday. I'm reviewing next Thursday. If we want to change that final exam, since those of you that are here, I need 100% everybody on board. I know there's a couple that won't be here for things that have talked to me about it. That's a totally different thing. But I need 100% everyone on board. If even one person, I cannot move that final. I have no problem doing it. I will do it. But I need everyone on board with it. Cool?
100%. All right. Thank you, Dr. Hodges.
Awesome people. Let's do this.
Everybody awake? Here, catch.
Oh.
All right. We're going to be throwing some things out into the crowd to keep you guys awake, all right? I'm going to make it kind of light today because one of my mentors passed away recently, Dr. Dennis Wogan. I don't know if you guys are familiar with him, but he taught Pettibon in Davenport from 1975 to 2000 and then started the Clear Institute, which was kind of an offshoot of Pettibon. And he's been doing that for the last 24 years. And I had a personal experience with scoliosis. So this was, when I was in first try, they described me at the Palmer Clinic as a 21-year-old first trimester student with an asymptomatic 68-degree curve, okay? And so as I learned about all these techniques, I'm like, is there anything preventative we can do with this 68-degree curve? And the answer was no. It was like adjust their neck, adjust their pelvis, you know, don't do anything crazy, you know. So I didn't listen to that. I played rugby. I had a rugby scholarship at Palmer. Dr. Hodges plays rugby. He's trying to get me to play with him, but I'm not going to do that. My days are over there. But in the first spring, I started school in October, and then in the spring of 1989, I was introduced to Dr. Dennis Wogan. He would come down twice a year and teach Pettibon. And it really was awesome because it was like, look, this is a whole spine biomechanical approach. And they were using it with people that had scoliosis, but it just wasn't that successful. And then he developed Clear, which has been very successful for scoliosis. And Dr. Hodges knows that I had my personal struggles with scoliosis, but my daughter Cameron, who's now at the Palmer Clinic, she's in 11th quarter or something like that, 11th or 12th quarter. And she had progressive scoliosis when she was 12 years old. And I was doing some things and it just wasn't working. It was getting worse and worse and worse. And we went to Dr. Wogan's clinic in St. Cloud, Minnesota. She got good results. Then I went through their program. I got good results. In all, you know, we were up there for about 6 weeks off and on. And I ended up getting certified and Clear. And then I opened up a clinic focused on scoliosis. And Wogan was a stickler for things, and he loved this quote by Lord Calvin. I often say that when you can measure what you are speaking about and express it in numbers, you know something about it. But when you cannot measure it, when you cannot express it in numbers, your knowledge of it is a meager and unsatisfactory kind. And maybe the beginning of knowledge, but you have scarcely in your thoughts advanced to the stage of science, whatever the matter may be, Lord Calvin. And when you get into biomechanical chiropractic with the work of Dr. Pettibon, Dr. Harrison, CVP, things like that, the subluxation is considered a deviation from the normal spinal model. And you can measure it in degrees and millimeters, and then you can also track your success in millimeters. This is the Pettibon textbook that was written by Dr. Wogan. He gave me a digital copy of it, so if anybody wants a copy, I can get it to you. So it's all about the ideal spinal model, and we're not going to get into all the details of that, but everything's measured in angles, and so your care plan is based on the measurable subluxation and what you found gets the best results with that. And you want to get as close to the ideal spinal model as you can, and this is the ideal lateral spinal model that Harrison created. So Wogan did a few things to make the lecture fun, okay? So Dr. Hodges is wondering, why does he have pantyhose? Well, Dr. Wogan was really into the alar ligament. Does anybody know anything about the alar ligament? We're going to talk about it because Wogan was fascinated by it. And why he was fascinated by it was because one of the primary causes of scoliosis is instability in the upper neck, which is caused by birth trauma from unneeded force on the upper neck. And these ligaments are so small, if you take an MRI of a baby, it's like smaller than dental floss. So it's very easy for these things to get ruptured. So Wogan would go like this. His head's the odontoid, right? Here's the alar ligaments, right? So if you rupture the alar ligament here, the C2 goes this way, and it creates a C1 overhang on this side, right? Everybody got it? Right alar ligament, left alar ligament, odontoid. Where do these alar ligaments attach? Occiput, right. What's your name?
Good.
What is it?
Good.
Jared?
Yeah.
There you go. So, Wogan also had some fun with some floats he showed up at a seminar with one time. So I recreated it. They've asked the Clear doctors to do some tribute videos for Dr. Wogan. So this is like a warm-up for a video that I'm going to do for an upcoming seminar we'll tell you guys about a little bit later. But you guys are welcome to come look at this in a bit. But we've got C2, C1, the occiput. These are the alar ligaments. And then this piece of foam is the odontoid, okay? And then you'll see behind the odontoid, you got the transverse ligament. So if you do an A to P open mouth lateral bending view, and you bend to the right and the atlas slides to the right, that's an indication of right alar ligament damage, okay? So what we just showed you was this ligament gets damaged, C2 will slide to the left, and C1 will go to the C1 will go to the right. C2 is the pink one. C1 is the blue one. So there's now an overhang on the x-ray to the right, okay? Usually, if there's a trauma, the C2 spinous will go to the side of the alar ligament, but usually in a chronic case, it's away. So anytime you see a huge C2 spinous rotation, that's alar ligament damage, okay? So it's important to know that because when you start learning how to adjust, you'll set up on people and you'll notice some people it's easier to make a cavitation than others, right? Now you need to realize some of those people that are getting these cavitations have ligament damage in their neck. And so, hey, let me adjust this guy because whenever we adjust his right atlas, it makes a huge noise. So when I do my practical, I want to set up on that guy, right? But it might not be the best adjustment for that guy's long-term health. It's just making a noise, right? And so if you tip your head up and it goes over to the side like this, that is a common sign of alar ligament damage. So then you do these A to P open mouth bending views, and you'll see the atlas translate on top of C2. So if it translates to the right, you wouldn't want to adjust the person from the left. That's going to cause more instability, right? Okay, so you guys are welcome to come up and look at my creation later. Anybody else?
Yay! Thank you.
This is one of Wogan's favorite quotes. It's the set of the sails, not the direction of the wind, that determines which way you go. There's our alar ligament, transverse ligaments. There's from the other side. So if the alar ligament on the right is ruptured, C2 is going to go to the left, atlas is going to go to the right. There's the bird's eye view of it. Not as good as what I just did. It's a lot easier to understand what I did, right? And then this is a conversation I had with Dr. Wogan on August the 4th. He passed away about a week later. But biomechanical doctors, and especially scoliosis doctors, upper cervical doctors, they are just really into what they're doing. Very detailed, like if you talk to Dr. Shreve, you know, we'll really get into the anatomy of things to the detail of, you know, like in the Blair technique, they talk about malformed condyles and how specific the adjustment can get. So this is a conversation I had him. I was asking about the C2 spinous deviation because I found sometimes the literature would say it deviates to the side of the alar ligament, sometimes it's away. And then he told me that in the acute cases, the spinous goes to the side of the alar ligament, but in a chronic case, usually it's away. And, you know, he was a mentor of mine, you know, since 1989. So it was, I had to come up with some of these fun things just to be able to talk about it without crying. And this is one of his favorite quotes. This is the end of his email signature. At the point in life where your talent meets your needs of the world, that is where God wants you to be. Albert Schweitzer. That's my CV. It's a lot of stuff on there. You can look on the website if you want to. One of the things in practice is you get to help people out and is celebrating their victories. This is one of our patients that's a swimmer at Florida, and this past year she was the 100-meter butterfly gold medalist at the SECs, and then she won her heat at the Olympic trials. But her event, the US has a lot of good 100-meter butterfly people. So literally at the Olympic trials, like 2 world records were broken. So they only take 2 swimmers, so she didn't have much of a chance to make the team. So one of the reasons I'm here is to fill a void in the education of scoliosis. It's not something that's really talked about at Palmer a lot. So a couple years ago, I talked to Dr. Shearer, and it's worked out that I've been able to share with Dr. Hodges' class. And so I appreciate the opportunity to be here. A couple fun facts about scoliosis. 80% of scoliosis patients have alar ligament damage. 80% of adolescent scoliosis is in girls. 80% of scoliosis curves are right thoracic, left lumbar. 80% postures are high right shoulder, high right hip. So you'll get to where you can just be in church or walking behind somebody at the grocery store. If they have a high right shoulder, high right hip, they will have a right thoracic, left lumbar curve. That's the most common scoliosis. You can't, like if you try to raise your right hip and your right shoulder at the same time, you can't do it because you don't have scoliosis. When you look at people that just have bad posture, their hip is high and their shoulder's low on the same side. So you can play around with that. And then when you see people, you'll be able to say, that's a scoliosis. Because scoliosis is actually a deviation within bodies of the spine. You know, these segments moving a certain way. And so it's abnormal anatomy. That's why if you don't have scoliosis, you can't do that posture. Only 5% of adolescents have scoliosis. 60% of senior citizens have scoliosis. So you can have adolescent scoliosis that progresses in an adult, but you can also have degenerative subluxation, especially in the lumbar spine, which will create a scoliosis in an adult. Scoliosis diagnosis must have the following: rib hump, 10-degree Cobb angle, pedicle rotation. If you're looking at an x-ray and it's taken P to A, then that's an indication that it was at a scoliosis clinic. Almost all scoliosis clinics worldwide take P to A x-rays. Do you guys know how to measure a Cobb angle? You know what a Cobb angle is? You might want to find that out. So expectations. So even if you're not a scoliosis doctor, it's important for you to give your patients expectations, because scoliosis has a natural course of getting worse, okay? So if you have a small scoliosis and you're 8 years old and that person has not had their first menstrual cycle yet, you need to alert those parents that this curve may get worse so that they're not surprised if it does. And then around 6th grade, when most people have their first menstrual cycle, there's a developmental process that occurs that if you truly have progressive scoliosis, all of a sudden this curve grows and takes off. If you don't inform the patient or come from a point of knowing, then the parents are gonna blame you. Why didn't you do something? Well, if you truly have progressive scoliosis, it's not a matter of anybody doing anything. It's something that was like predestined for that person to happen. And we'll talk about prevention, but it's important that they all know this. And if we have a scoliosis patient that's pre-puberty, they all sign this so that they have an idea of what could potentially happen. And then at the end, you'll see during middle life, the curve usually only grows a degree or so every year. When you get to post-menopause, it'll take off again. And then after 60, the curve may increase 3 to 6 degrees a year. So like in this area of Port Orange, there's gonna be a lot of adult progressive degenerative scoliosis. The traditional medical scoliosis model, 10 to 25 degrees is mild scoliosis, watch and wait, which to me, as a scoliosis patient, it's like we have the greatest opportunity to do something, but in the medical world, they tell people we're gonna watch and wait. It's too small to brace, it's not bad enough for surgery. Everything in their model leads to surgery. They even have some scoliosis hospitals that are offering some preventative things like Schroth exercises and stuff, but in my mind, it's just something to put the mother off. They're like, go ahead and do that. Then when it gets worse, we'll do surgery. What about bracing? Okay, we'll do that. When it gets bad enough, we'll do the surgery. Everything leads to the surgery. And when you look at scoliosis research and the amount of projects that are done on preventative versus surgery, it's minuscule. And it all comes down to money. These scoliosis surgeries are like $200,000. You know, for somebody to go through clear program is, you know, $5,000 to $10,000, and there's no money going into the medical community's pocket. So everything goes to surgery. Moderate is 25 to 40 degrees. That's where they do medical bracing. And then when the bracing fails, then they recommend surgery, and that's 40 degrees and above. Earlier intervention is the logical answer to preventing scoliosis. School screenings are in 6th grade after asymmetrical bone growth occurs. We'll talk about that a little bit. Adams test is indication that surgery is already needed. Does everybody know what Adams test is? Maximize spinal health before puberty. So get things as good as you possibly can before puberty. In our office, our scoliosis screening paradigm is we screen all students K through 12. Parents receive an annual report of the Scoliometer. You'll see what that is again, and postural findings. We inform the parents so that they're equipped to make early decisions. They know what's going on. The subluxation is reduced prior to Hooter-Volkmann principle. Hooter-Volkmann principle is when these hormones kick on and you get this asymmetrical bone growth of the spine. So for most people in the mid-thoracic spine, the anterior left spine stops growing and the posterior right spine expands like that, and you get the rib hump and the right thoracic curve. And you'll get the positive right thoracic Adams test. The Scoliometer is a level that we use to measure the spine. You'll see in a second. And 7 degrees on there is equivalent to 20 degrees on the x-ray. So that's me doing a spinal screening. And there's a little BB on there, and it moves to give you a rough idea of the curve. And it is pretty accurate. It doesn't always match up with the x-ray, but it gives you a rough idea of the curve. So the Adams test is also called the too late test. Anybody have any ideas? Why would it be called the too late test?
It's too late.
Because it's too late. Once the Adams test shows up, the rib is already deforming. The bones are already starting to deform. So for you to visibly, like for a nurse, easily to see the ribs deforming on a school screening, things have already gotten bad. It's like they're probably already headed towards surgery. This is a patient of mine, and on our initial Adams test, so Adams test is when you bend forward and you're looking at the rib arch. It's more accurate in the thoracic spine. In the lumbar spine, you're dealing with a lot of muscles. So in general, if you have a patient that went to a pediatrician they have a positive Adams test, and they're talking about the thoracic spine most of the time. So you can see this significant rib arch, and we're gonna follow through this patient on a couple pictures. So she went through corrective care in our office, and you can see as her curve reduced, that Adams test went away, okay? So her age, large curve, 34 degrees. She hasn't had her first menstrual cycle yet. She goes to the Children's Hospital. They're telling her, you're gonna need surgery. And that's what they told this person. So with her care in our office, the rib arch decreased. This is a chart showing the Adams test. So you can tell she got 3 inches taller, but the curve reduced and the Adams test and the scoliometer all reduced. So you know you're on the right track. When you have big growth, usually these progressive curves are gonna get worse. If they stop getting worse, then you know the curve probably is not gonna continue to increase. So her curve went from 34 to 12 degrees. If it's below 12 degrees, then she no longer would be considered to have scoliosis. Now she's maintained being in our office, and she's had her first menstrual cycle now, and the curve did increase a little bit when she had her first menstrual cycle, but it didn't go back to where it was. This is her wearing her Scoli brace. So we're a certified provider for Scoli brace. A lot of Clear, Pedibon, and CVP doctors are now using Scoli brace. It's a 3-dimensional overcorrective brace. And when she's wearing the brace, her 34-degree curve goes to -3. And she wore it 20 hours a day. Now she's just wearing it at night. Like we already talked about in the scoliosis clinic, the x-rays are taken P to A to reduce radiation to the breast. Now, I don't think I put it in this presentation, Dr. Hodges, but last time I think I talked about the linear radiation model. But it's something driving down here, I was listening to the radio and they were talking about this study with the fruit fly. Did you hear about that? So they've mapped the fruit fly brain to where they actually have every single neuron of the brain. And so they're gonna use that to help with human anatomy, because a lot of your reflexogenic things in your nervous system are very similar to the fruit fly, you know, as far as frontal lobe, posterior lobe, different tectospinal reflexes and all this thing. You know, you think you try to get a fly and it jumps, right? Tectospinal reflex. When we do some of our stability exercises where the patient is on an air disc, they're standing on an air disc on top of a vibrating platform. Here, catch. And so we have them reading a word search. They're on an air disc on top of a vibrating platform with these weights that are correcting their scoliosis. And then they'll hear something and their head will go like this, Dr. Hodges. And I'm like, oh my gosh. Like, so in neurology, that's like an overdeveloped tectospinal reflex. It's like, here, everybody got one of these. But the linear non-threshold radiation model is based on fruit flies. So what they did is in the 50s and 60s, they did these radiation experiments and they irradiated these fruit flies, and what they came up with, their final conclusion was that more radiation, the more mutation, right? And they just created a straight line. And since the 1950s and early 60s, everybody just assumed that was the accurate model, right? So recently, there was some retrospective analysis done on the actual data of that research. And the writer of the paper failed to disclose that when the fruit flies first started getting radiated, and then they separated those fruit flies out, they actually lived longer and had less cancer than the ones that they kept radiating. So what that showed was there was a healthy amount of radiation that actually helped the genetics actually be stronger. Like taking a walk on the beach or taking a transatlantic plane flight is giving you radiation, your body responds to it like exercise and actually makes it stronger. So that is why, like in a lot of places, if you go to a medical facility now, they won't use gowns and stuff like that because they're using the information from this study. But it's important to know this when you're in a scoliosis clinic where we're doing a lot of follow-up x-rays. We now can tell these patients, look, there's like if you're below a certain amount, it actually makes your genetics stronger than if you didn't even get the x-ray. And so there's a lot of controversy because you get some people that are still under this linear model and they'll have these debates, it's really interesting. But as a chiropractor, it's important to be able to talk to a patient because they're going to ask you questions. I'm worried about this x-ray. Well, the information is more important than the radiation. As a matter of fact, the radiation might actually make you stronger. So we're going to talk about the Cobb angle in a second, but the Cobb angle is the angle of the curve. How bad is the scoliosis? When you do a bending view, the fixated curve is actually considered the primary curve. So it's a functional description, not necessarily the largest curve, okay? The flexibility of the curve can be a predictor for outcomes. So if we do a bending view, that tells us that they're probably going to look better in the brace. Their exercises are going to be able to reduce the curve. If we do a bending view and they don't have any reduction, then we're telling them, it's going to be hard to correct this curve. And you take the guesswork out of it where the patient is not surprised if they don't get the results that they're anticipating. So the Cobb angle, you take the scoliotic curve, you look at the steepest vertebra at the top and you draw a line, and then you go to the steepest vertebra at the bottom of the body, draw a line, and then you take a tangent to those, and A is the Cobb angle, okay? So it's important to know this as a doctor because if you're seeing a scoliosis patient and these Cobb angles are increasing, you either need to change what you're doing, refer up. So I have a diplomat in neurology and somebody taught us that the chiropractors don't necessarily need to refer out. There's plenty of places that you can refer up. You can refer to a more experienced doctor. You can refer to somebody that has a neurology diplomat. You could refer to somebody that has a specialty in scoliosis. It doesn't necessarily mean you need to send them to a medical doctor, but if you don't have a hold on a scoliosis that's getting worse, then you need to do something. You need to document, you need to talk to the family, what are we gonna do different? And if this doesn't get better, where are we sending you? Scoliosis spines demonstrate abnormal coupling in lateral bending. Spinous process rotates into the concavity with lateral bending. So in a normal spine, when you bend to the left, which way do the spinuses go?
Right.
You can't answer all the questions. Anybody else here? Catch. Just since you answered that, you get one of those. So when you tip to the left, spinous goes to the right. In a scoliotic spine, it's just the opposite, right? And the body wants to relieve dural tensioning and tethering. So some of the other theories of scoliosis is you can have asynchronous growth to where the spine is growing faster than the spinal cord, but you can also have adhesions inside the spinal cord, kind of like what SOT talks about, where you have dural adhesions and all these type of things. Like Dr. Shaw talks about flossing and stuff like that with the nerve root where it connects to the spinal cord. All that can cause scoliosis. The body's looking for a way to get rid of the stress, and it's easier to go through the valley than over the mountain. That's the spinous rotated to the concavity. Everybody visualize that? Who can't visualize it? Who can't visualize it? All right, so on the bending view, the 27-degree curve goes down to 4, and then in the lumbar spine, the 20-degree goes to -11. So where's the major curve? The one that reduced the least. So the 27 to 4 reduced 23 degrees. The 20 to -11 reduced 31 degrees. So the right thoracic is the primary curve. This guy had an incredible correction. He went through intensive care in our office, which is where you come in for 2-hour sessions twice a day for 2 weeks. He lives in Pensacola. He sees an upper cervical doctor there. And so I haven't seen him for an adjustment now in like a year and a half. But he continues to use the brace, do his home exercises, and get a regular adjustment. In his curve, he just came in for another x-ray. It's actually reduced even less than this. So now he no longer has scoliosis. So he went from 27 to 11. When you're a 12 or 13-year-old boy and you have a 27-degree curve, odds are, because your hormones haven't kicked in yet, it's going to progress to surgery. So this was a really good case. Red flags. Do you guys have much clinical stuff? Do they know anything about red flags? Does anybody here go to the beach? I know people only go to Palmer, Florida because they want to go to the beach, right? They don't want to go to Davenport because there's no beach. Now in Davenport there is a beach. Dr. Hodges was just up there. There's little lakes. And when you're from Florida, it's kind of funny. Like your friends are like, oh, we're going to the beach, you know, whatever. And you're like, okay, we'll go there. There's going to be girls, beer, whatever. And you get down there and it's like a mud hole, you know, in the middle of a park. And people are acting like they're at the beach. When I took a recruiting trip to Davenport, it was in April. And I had a chance to play rugby there. And I just heard a lot of good things about Palmer, Davenport. And so I go there in April, and there's a park just north of the school, and you probably drove past it, Doc. Just north of the school up the hill, there's a park, LeClaire Park and Vanderveer Park. And all these people are out in their bathing suits, and they are like lily white. And I'm like, and it's like 65 degrees out. And I'm like, what the heck is going on? Well, I found out the next year, because nobody went outside for like 3 months, and that day in April was like the first day the sun came out, and so all these people were out in their bathing suits and totally white in the park, you know. That was a red flag that it was going to be cold in Iowa. So, red flags, scoliosis curve before puberty. Usually you're not going to get scoliosis before puberty. So if you have a patient come in that has a 40-degree curve and they're 6 years old, bing, 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 that's not, something could be wrong. If they have a left thoracic, right lumbar curve, most curves are right thoracic, left lumbar, that's 80%. So if they're under puberty, but they have a right thoracic, left lumbar curve, you're not as worried, especially if they have a family history of scoliosis. There's no genetic test for scoliosis. They did at one time think they had one for progressive scoliosis. Cameron took the test. She passed it. She said, good, you don't have progressive scoliosis. Guess what happened? Her curve progressed. It was an invalid test. They sold it on the stock market and everything. It ended up, the whole thing fell apart. It wasn't accurate. But there is a family history. There's a lot of recessive genes involved. And so they can't figure out exactly how the genes are. But my mom has scoliosis, 2 of my daughters have scoliosis, I have scoliosis. It runs in families, okay? So you can let people know that. If you have a 7-year-old male with progressive scoliosis, left thoracic scoliosis, what are you thinking? It's more prominent in females. Right thoracic's more prominent. Now you got a 7-year-old boy with a left thoracic curve. Anybody? You can't answer every question. What? That's okay. We got to give these people a chance. All right, he's smiling. Okay, what are you thinking, guys? Differential diagnosis. Transient juvenile scoliosis. So there is a group that with smaller curves in where they're just, the body's going to adapt. We have this innate intelligence. So you're going to start off with a left thoracic, right lumbar curve, you get your upper neck adjusted, and the curve goes away. The body's just adapting as the body grows. There's like an intelligence, right? Progressive juvenile scoliosis, that's not good. Arnold-Curry formation, do you guys know what that is? Did you get one of these yet?
Yeah.
Okay.
You have C2.
You know what the atlas is. We don't have a C2. But when you have a bony obstruction and you get a cerebellar tonsil coming down and through this area, it can cause a scoliosis. That's what the Arnold-Curry malformation is. And they will do surgery on that. There's anybody seen the video with Jim McMahon getting adjusted? It's like a story about the 1985 Chicago Bears. He has really debilitating headaches and concussion. And it shows him getting an upper cervical adjustment and his cerebellar tonsil actually getting better and the blood flow in that area getting better. But people get surgery if this malformation isn't bad enough, but that pressure on your upper neck will cause a scoliosis. Tumor, which could be in many places. Syrinx, does anybody know what a syrinx is?
I don't.
Anybody? Okay, these are fluid-filled cysts in your spinal cord, and your body doesn't like to be near them. They can get larger, they can get smaller. Sometimes they progress. They can be drained, but they're usually always going to be there. So I have had some symptomatic scoliosis patients where these things will swell up, they'll hurt more, and then the swelling goes down and they go away. Not a lot of definitive answers for that. Congenital malformation, if you suspect a congenital malformation, would you do an MRI or a CT?
An MRI?
Who said that? You already got one of these.
She did.
Okay.
She can get one.
Give her, you can have yeah, you're gonna do a CAT scan because you're looking at the bone. CAT scan is more about the bone. And you can order these things. Dr. Hodges, I think I have a different slideshow. It shows the 3D CAT scan. And that is really cool. So, I mean, I just order them for fun now. If I know I'm going to get a CAT scan, I just say 3D CAT scan. And so, when CAT scans first were evolving, if you were in the imaging center, you could kind of spin the bone around and separate it three-dimensionally. Now, you can actually see that in the office computer, the doctor's office, and it's really incredible. So you can see some degenerative things that are just amazing to look at. Yeah, that's right. So last time I was here, I had just done one on a patient, and she had surgery on her neck, but she had a complete reversal of her cervical spine. This curve was so bad that I think what happened was that when they put the screw in to fuse the spine where the reversal was, it didn't make it to the bone because the plate was here, here, and here, and they got the screw in here and they got the screw in here, but when they put the screw through the plate here, it didn't make it to the bone. So she had this piece of screw like in the front of her throat. It was just like floating around, and I showed it to her and she like freaked out. I'm like, I don't see how that was in there. Like, I think that's how they left the surgery. I'm like, did they do another image after the surgery? No. I'm like, for sure that guy did not get the screw in the bone. So it's just floating around in her neck. So if somebody has a progressive scoliosis, what regions are you going to do an MRI? If you decide it's an abnormal curve, you want to do an MRI. What regions are you going to do an MRI of?
Head and neck.
Well, you have the brain, cervical, thoracic, lumbar. Somebody shout something out. Come on. Who said thoracic? Okay. So any other ideas?
Lumbar.
Who said lumbar? Okay. Any other ideas? Ankle? No, already. Okay. There's causes of scoliosis, right? So where's the scoliosis coming from? 80% of scoliosis patients have upper cervical instability, right? But they also may have brain tumors. They may have some of these cysts in their spine, and they may have tumors in their spinal cord. So if I order an MRI on a scoliosis patient, I'm ordering brain, cervical, thoracic, and lumbar. Because why would you do one section? You totally could miss it, right? Already talked about, this was a patient that came in this year. So she had, that's her CAT scan. She had a congenital fusion at T4-5, which was creating some of her scoliosis. But when we do a bending view into it, it actually still reduced about 50%. So then we had a goal of some reduction, but we know she's always going to have some scoliosis, and that's her Adams test. You can see on the left there, where you see the little rib arch. So there's theories of the causation of scoliosis, all right? Upper cervical instability, family history, hormones, secondary, biomechanical, abnormal curves. We're going to talk about that in a second. Disc pressure, ligamentous creep, neurological, cerebellar asymmetry. And it's amazing, like when I was in Carrick's program, and he would talk about cerebellar asymmetry and hemisphericity and this stuff, I mean, you thought you were crazy. Like if you talk to anybody out there, medical doctor, neurologist, they had no idea what you're talking about. And now this stuff is popping up in the research all over the place. We're going to talk a little bit about pregnancy and birth, right? Because it's real important. This is my daughter Cameron, who's now in 11th quarter. And I have a 2-year-old grandson that she gave me. And so the mother, her genetics are a factor, and hormones are a risk factor. They even have studies that show low vitamin D when you're pregnant is a risk factor for scoliosis. They have studies that show chlorine, more chlorine in the water, increased scoliosis. They have studies that show calcium levels, more scoliosis. It's amazing. So if you don't want the kid to have scoliosis, you want to have a natural childbirth. You want to avoid forceps injections, C-sections, which may result in alar ligament damage. How could a C-section cause alar ligament damage? The baby could already have dropped into the canal. 2, they may be trying to limit the incision size. So just because it's a C-section doesn't mean there's no trauma to the neck. There's a great book you should all read called Birth Without Violence by Dr. Frederick Labouré, and it goes through birth from a child's perspective. It's really amazing. But do you want to come into the world in a 60-degree room, laying on your back on a metal table, and then they put silver nitrate in your eyeballs and say, hey, welcome to the world? So he offers a different perspective to that. Importance of preserving the fetal curve at birth. So he talks about the baby's born, they've been in a fetal position for 9 months, and they lay them on a metal table flat on your back. Do you think that's going to feel good? Now, if you don't want scoliosis, you want to preserve that thoracic kyphosis. And we're going to talk about the bucket handle effect in a minute. If you take a national board exam and they ask you, how do you adjust the scoliosis patient? And one of the options is high side of the rainbow. You pick that option. But in practice, do not do that. It'll make the curve worse. I have had a bucket in here before with the handle, right? So if you think about the bucket handle as the thoracic spine, right? If the bucket handle is to the side at 45 degrees, like it would be in a 40-degree scoliosis, and you push straight down on the bucket handle, which way is it going? Further down, right? Which will make the curve worse. So do not adjust thoracic scoliosis P to A, or the high side of the rainbow. Birth, stimulation of bodily function. So Carrick talked about, yeah, birth is one of the most traumatic things you'll ever go through, but it was innately done that way on purpose. It's a wake-up call. The baby's gonna come out, it's gonna have to breathe, go to the bathroom, and nurse, okay? When it gets that pressure on the brain, it's stimulating all those things to happen. It's the wake-up call, right? It's kind of like when your kid turns 18 and you change those locks, right? Dr. Hodges didn't have to do that, but it's a good idea. They turn 18, you change the locks, they try to get back in. Hey, what happened? So it's kind of nature's way of doing that. Other thing that happens with the mother will let down her milk, right? And she automatically has a hormone change in her body if it's a natural childbirth. Now, if you take that same mother and you don't have a natural childbirth, medicated surgery, the body doesn't even know that the child was delivered. Now you have the wrong hormones in the body, the milk doesn't let down, now the baby has a hard time nursing. So let's say you have a C-section, both is it not stimulating the baby to start to nurse, but the mother's also not going to let down. So your odds of that, and if the bacteria that you get from a vaginal birth and that initial milk that you get at birth, you cannot replace that. If you do these studies on gut bacteria, like everything that you can possibly do the rest of your life is minuscule compared to having a vaginal birth. It's like almost like a waste of time. You hate to say it's a waste of time, but it's kind of a waste of time. Having that initial seed of the bacteria at birth is the most important thing you can ever have happen. Potential for alar ligament damage. Oh, on this picture, see Cannon's eyes? As soon as he's born, babies that are born naturally, their eyes will be open, they can focus, and they're cooing, right? I have seen babies born C-section that are 2 weeks old that still haven't opened their eyes. So this is what the alar ligament damage looks like. So when that atlas slips over the top of C2, there's like an overhang, okay? And this one has alar ligament damage bilaterally. I was at the University of Washington, St. Louis, and they had a poster up. They're looking for people to help out with a research project where they're studying upper cervical instability in scoliosis. So chiropractors need to be aware that other people are studying this, and if we don't take ownership of it, somebody else will. Dr. Wogan talked about 80% of scoliosis patients have been found to have alar ligament damage, and even if you don't have scoliosis, if the patient looks up like this and their head goes way over to one side, they tend to have alar ligament damage. If you have a patient that's been to another chiropractor and every time they get adjusted with the manual adjustment, they throw up, they get a headache, they get nausea, I would take this alar x-ray because it could totally change the way you adjust them. It could just be that manual adjustment is making it worse. So if we see the head tilt, right head tilt, you're thinking left alar damage. With infants, we do a lot of photos. So if the baby's in a car seat, we just say, don't move them. I take a picture of them. We have a grid on, we use ChiroTouch. We have a grid. I take a picture of them in the car seat with the grid. And then you look, is it the same? Even if they're not a patient yet, I'll put it in the mother's file. Let's take a picture. If the head's always to the right, 5 consecutive pictures, there's a problem. If it's to the right one time, to the left the other time, that's just normal. We'll do hanging photos. So once the baby's comfortable with the clinic, they'll lay on their back. The mother will take the ankles like this. They'll hold them up in the air like this, and we'll look at their posture. So this is something CVP started doing, years ago. And it's a very effective way to monitor their posture because they can't stand up. So we take a picture of their hanging posture, and then it lets us, it's like a pre and post evaluation on a newborn. Lateral curves. So when we're looking at scoliosis prevention, in biomechanics, everything starts with the lateral curves. If you lose these lateral curves, then other things start to happen. So when the baby's born, we already talked about, we want to maintain this thoracic kyphosis. We want to avoid front packs, Johnny jumpers, walking saucers. They're loading the spine up prior to the body being strong enough. So if a baby can sit up on their own, then it's okay to sit them up. But don't be like sitting them up. Here, he can sit up. Here, he can sit up. You're putting the load on the spine before they're ready. Same thing with walking. Like a baby will pull themselves up on the couch or the bed, and then you know that they're strong enough to do it. But you don't want to be placing them in that position because they're not ready for it yet. In Europe, there's a lot of socialized medicine. One of the primary treatments they do for scoliosis is all they do is give them a thoracic kyphosis breathing exercise. We'll show you that in a second, but that's how important they feel like it is. Rather than the front pack, we like the sling. So you put the baby in the sling, it's holding that fetal curve in there. That's how they were in womb, and until they start to do the tummy time, that's the way to go. Risk of progression to severe scoliosis. If you have a loss of thoracic kyphosis or even a thoracic lordosis, the odds are that's going to progress to surgery. we've had patients come in with a 20 to 40 degree thoracic lordosis. So we're taking the side view x-ray. They actually have a lordotic, kyphotic, lordotic thoracic spine. And that's an indication if they don't have a scoliosis yet, they're probably gonna have one. Anybody recognize that bridge?
Bridge Alliance.
Yeah, that's where I practice in St. Augustine, Florida. You guys are welcome to come visit. This is the breathing exercise they do in Europe. And so it's like they're pressing against you as they take a big breath in. They're using all the lung muscles to try to create that thoracic kyphosis. That's her with a full breath in. This is her breathing out. So if any of you were on a table, unless you have a 40-degree scoliosis, you're gonna still see a thoracic kyphosis here. She actually doesn't have one. This is what when they say dorsal scalloping, and this is what they're talking about. The middle back is actually going like that. So what things would you avoid if you don't want scoliosis? So they've done studies in Australia, and what they did was looked at people that already have scoliosis, then they looked at what activities they were doing, and then they measured, did the Cobb angle get worse? So rhythmic gymnastics was number one. So if you have a thoracic scoliosis, and you have a loss of your thoracic kyphosis, this might not be a good exercise for you to do. The other ones that made curves worse were volleyball, think about it, thoracic extension, ballet, they do a lot of back bending. Competitive swimming is a risk factor. They're not going into hyperextension, but all the stabilizing muscles for thoracic extension are being used. And the swimmer from Florida is a scoliosis patient, and we've been able to help her performance and prevent it. Activities like running, soccer, and lifting weights, believe it or not, are not a risk factor. The lateral curves. So 3 to 6 months, you develop the cervical lordosis, and the baby innately will do the tummy time. If you just lay them on their stomach at 3 months, they're gonna pop their head up. Some kids will even do it younger than that, but that's when they're developing that cervical curve. So if you don't have a cervical curve, either you've had trauma to your neck or you didn't do the tummy time. 6 to 12 months is when you develop the lumbar lordosis, and that's when you want them to crawl. I used to take my grandson and I would put a toy on one side of the room and make him crawl to the other. And then his mom went, "Oh my God, you're torturing him." No, we're like, this is cross crawl. This is helping his neurodevelopment. It's very important. And they know that patients that go from sitting, from walking, from crawling to running, and they miss some of these steps, they never cross crawl, they're more likely to have scoliosis, they're more likely to have neurodevelopmental problems, ADHD, and they'll have clinics in adult. You need one of these. And so they'll have adults in these clinics walking around crawling on the floor because they're catching up from missing those steps. There's my grandson, tummy timing it. And then what we start to do, Dr. Hodges, is we'll start to do cross crawl. So before the baby can crawl, we'll passively take them through the cross crawl, and then we'll actually make a neural connection where we'll have them touch their hand to their toe, and then we'll do it the other way. So we're developing these neural connections even before they do it. And then we'll have the parents do it at home. So we will have more neurogenic diseases, unfortunately. I mean, it's a lot of patients for the chiropractors and the surgeons, but for the health of the population, it's just not good. So why do we have more subluxations? Like people say, you know, old chiropractors will talk about the monthly adjustment and, you know, how, you know, the patient didn't need to get adjusted because they weren't doing this. They were out like feeding the pigs and throwing hay and stuff. This is going to cause some serious neural tension. So when I see a kid in my waiting room, we put an air disc on the table, we give them these prism glasses, and we're like, now get on your phone. Does that look better? So this kid came in the office, the parents noticed his posture was kind of funny. he had a kyphotic lordotic lumbar spine. When I was in chiropractic school, the only time you would see this is if somebody had a tumor or something. Okay? So he went through 12 visits of corrective care in the office and completely restored the lumbar lordosis. Tertiary curves in Pedibond and CVP, that's the occiput and sacrum, the fourth and fifth curve. Now, this patient came in referred by a chiropractor for scoliosis, and a lot of times we get a lot of referrals. We have to determine what's going on with the patient. So we gave you the rules of what is a scoliosis. Does this patient have a scoliosis? Who said no? It was one of you guys. I heard it. Okay, give that to somebody else. So if you look at the pedicles, there's no pedicle rotation, and the cob angle is less than 10 degrees, right? So that patient doesn't have scoliosis, but they did get better. They went down to 0/0 in the office. That was awesome. Now this patient initially had a kyphotic lumbar spine. We corrected it. He stopped doing his exercises and it came back. He probably was doing a little bit of that phone stuff like that other kid, playing games and stuff. When you look at the research, people are always looking, what causes scoliosis? Is it genetics? You know, everybody's looking for one single thing. And when you talk about subluxation in the brain, you can't say it's one single thing. Like you can't say vitamin D causes scoliosis. You can't say that it's hormones. So this is a good paper, and it talks about multifactorial cascade concept. So it goes through all these different potential things that we've already talked about in our list. And then you look at this poster that's in one of the papers I read. It talks about contralateral cerebral hemisphere dysfunction. Okay, this is what Carrick was talking about. This is a cause of scoliosis 25 years ago. I got my diplomat in 1995. He was talking about this, the rib expansion causing scoliosis. And then when you already have the dysfunction, the hormones kick in, and then the bone starts to change its shape, right? So we can do a lot of preventative things before that. There's an Italian clinic in Milan called Isica, and when people ask them about prevention for scoliosis, they said there is nothing you can do. When you see a rib arch, and when you have a greater than like 20-degree curve on your x-ray, then come to see us. It's kind of like homeopathy. I was like, okay, homeopathy, it's natural. It's like, we should go to a homeopathy for prevention, right? So you go to talk to a homeopath, okay, I have nothing wrong with me, I want prevention. They're like, we don't do that. We can't treat you if you don't have a symptom. It's like, chiropractors are totally different. It's like, we're always thinking about, you know, prevention or the cause of it, catching it earlier before something happens. So things that we're looking at on the x-ray, backward tilt of the vertebra, which is like a break in George's line. You guys know what George's line is on x-ray? You do? You must take a Gonstead, right?
Radiology.
Huh?
Radiology.
Okay. So, I mean, if you're a Gonstead chiropractor, even we use a lot of George's line, that tells you that the segment's gone posterior, and then you got anterior longitudinal ligament damage or instability, and we're usually going to do a PDA adjustment on that segment. Vertebral rotation, spinous rotates the concavity, rib asymmetry, breathing issues. We'll show you where the thoracic spine kyphosis is inversely proportionate to the scoliosis. Concave creep of ligaments. So in Pedibond and CVP, they talk a lot about ligamentous creep. And Dr. Hodges and I are talking about one of the things we do with the patient is we warm them up before they get adjusted, because on the concavity of the curve, even if it's less than 10 degrees and it's a subluxation, that ligament is getting shorter over time, and it's going to create resistance to the correction. So we want to work on that. And scoliosis is more prevalent in people with low muscle mass. And so when the Suter-Volkmann principle starts to occur, this is the bird's eye view. So we will start to get this deformation of the actual bone. Are you guys familiar with the Risser sign? You are? What do you know about it? What about it?
There's 4 grades and it's on the crest of the iliac.
5. There's actually 6.
Oh, really?
Yeah. If you have no Risser sign and you haven't had your first menstrual cycle yet, that's 0 negative. Then you have 1 where you start to see it right here on the edge of the ilium. Then 2, 3, 4, 5, right? And then as it fuses into the ilium, it's going to disappear again. Now you're 0 plus. So there's actually 7. And that's a pretty good indicator. So if somebody comes in and they have a 25-degree curve and they're 10 years old and their wrists are 2, you're nervous. You think this curve is going to increase, right? If they're 14 years old and their wrists are 5 and their height hasn't changed in the last 6 to 12 months, then the curve's probably not going to get worse. But this way you're coming from it from a point of knowing, you're not guessing, because you're going to see all kind of weird things, and the patients are going to be extremely stressed. A lot of them have just been to the Children's Hospital and they're having surgery recommended or bracing. So, you got to either know about it or know where to send them. So this one, age 6, she's been under care for a couple years now, and I'll give you an update on her. But if you look at the curve, the x-ray on the left, does she have scoliosis? She doesn't? You guys disagree. Why don't you think she has it?
It's over 10, so she does.
And what else? You need something else. You have to have pedicle rotation and the 10 degrees. Otherwise, in the scoliosis world, they don't consider that scoliosis. Because you can have a neuromuscular scoliosis. So if you have a neuromuscular scoliosis, it's more likely that it could be coming from a tumor, genetic condition, all kind of different carotid malformation, things like that. So on her follow-up x-ray, she looked better, but we just did her most recent x-ray. She had to get a new brace because her curve progressed again, then she got a new brace. She is like 0 over 0 now. And the parents are just being proactive. They don't want to wait until it gets to 25 degrees for a brace. So we have that we offer people. So this patient, do they have scoliosis?
No.
Come on, guys.
No.
All you have to look, do you see any 2-digit numbers? No. They have pedicle rotation, so you're concerned. Oh no, this is that same patient in the brace. So in the brace, she still has some pedicle rotation. Her second brace x-ray looks better, but there's still some pedicle rotation. We took an x-ray just recently in the second brace she had to get, and it totally took out reversed everything, so it went to negative. When we're looking at growth, when you have your first menstrual cycle, the year before that and year after it is the most dangerous time. That's what that's talking about. They're looking at muscle activity that they're monitoring electronically in the scoliosis, which there is an asymmetry there. D.D. Palmer talked about life is the expression of tone. In that sentence is the basic principle of chiropractic. I feel it is my bounden duty to not only replace the displaced bones, but to also teach others so that health and spiritual may enjoy health, happiness, and full fruition of our healthy lives. And that is just so true today. When you see the directions people are going in, what they're searching for, we have a lot to offer people. So this is a medical model. So when you look at exams in scoliosis, you have a lot more leeway. Like if you have a scoliosis patient and you're doing a follow-up x-ray every 6 months, nobody's gonna ask any questions. Because there's a huge liability with a scoliosis patient. The worldwide standard is x-raying up until age 18 every 6 months. So be aware of that, and there's plenty of references, and this is showing you a few other things you're monitoring. Cobb angle, Risser sign, triradiate cartilage, which is like a piece of the pelvis that fuses as you get older, growth plates in the hand, growth plates in the elbow. Everybody has their different things they look like. If you go to a certain children's hospital, they're gonna look at the pelvis. Another one's gonna look at the hand. They all give you information, but just like the Adams test, they don't tell you whether the curve's gonna get better or not. It's like there's an overall picture, and these are all just pieces of the puzzle. You can't look at a hand x-ray and tell somebody your curve's not gonna get worse. They do that at the children's hospital all the time, but there's multiple factors, so it's just one piece of the puzzle. Just talked about that. This is a European model where they're x-raying every 6 months, age 8 to 17. We talked about the growth, both in height, but in the growth plates, there's a dangerous window where the curve progresses. So we have a unique opportunity when we're correcting these patients. We have this Hooter-Volkmann principle, and it's going to expand and make the curve worse if we don't do anything. But now think about that same patient in a brace that's a mirror image brace. So the brace is mirror imaging them in the complete opposite direction of their scoliosis. Now those hormones hit the body, and you have these osseous things happening in the bone. You can actually use that Hooter-Volkmann principle actually to correct the subluxation. So this is something that is they talk about in the bracing world, but it's really, the patients grasp onto it. So it's a really important way to educate the patient. And it lets them know, look, your child's 8 years old, you have like 4 years to get this taken care of. Because when the hormones kick in and these bony changes happen, it will reach a point where it's irreversible. So we need to monitor and do everything we can to correct the spine. This guy just came back in yesterday for a re-exam, and he's holding his correction. And so he is 13 now, and that was 6 years ago. So he came in when he was 7 years old. Did he have scoliosis? Well, he had the 11-degree Cobb angle in the lumbar, and he has some pedicle rotation, but not a lot. On his lumbar x-ray, it looked a lot worse, and you can see he really had a nice correction the first part of his care. But that one, like in CVP, they might call this scoliosis, or like if you go to a Gonstead doctor or something, I got rid of their scoliosis. This person didn't have scoliosis. It was more of a neuromuscular scoliosis. The pedicles aren't rotated at all, but the Cobb angle did decrease. Disc pressure. So there's some weird developmental things that happen in these scoliosis patients where they have a lot of disc pressure, and just like they're trying to get away from this tethering in the spinal cord or asymmetrical growth, the same thing can happen with the disc. And so when we think about prevention in chiropractic, like if you have a kid that has this abnormal disc pressure and they're getting adjusted preventatively, the negative effects of that are just never going to appear. They're getting adjusted and the pressure goes away. And so then the scoliosis never develops. So it's a preventative aspect. The spine buckles with this abnormal disc pressure. This is showing a graph of the thoracic kyphosis in scoliosis. So you can see how they're inversely proportionate. So as you lose that thoracic kyphosis, you gain a scoliotic Cobb angle. So it's super important. Once you have a scoliosis, do not adjust those people PDA. You will make it worse. And I think Cameron said you guys do teach anterior adjusting. Now, in biomechanical adjusting, the idea is you're trying to get the spine to go in like this when you adjust them anterior. So you're taking the dorsal scalloping out. like the knife edge way like this, where you're taking the spine over your hand, that still don't do that way, because that's gonna make the anterior be worse. Anybody asleep? The guy next to you is asleep. I got some more of these to give away, guys. We gotta get going. So this disc pressure, and I have had these kids come in where this disc pressure is causing the scoliosis, and these are some really tough cases. But we will never know the preventative aspect. Most of these discs don't generate any symptoms, but they can create all kind of weird misalignments. So when we talk about prevention, loss of cervical curve, lumbar lordosis, anterior head translation, loss of thoracic kyphosis, results in the buckling effect. We want to avoid the PDA adjusting on the thoracic, and we want to restore the lateral spine corrective care. There's a lot of different techniques that do things like that, mainly CVP, Pedavon, techniques like that. This is a patient that came in, and she had severe migraines. Anybody here ever had a severe migraine? When I came to Palmer, I would get these headaches, right? And I went to, I started going to the student clinic, and later on in the curriculum, we're studying headaches. Like, this is like years later, and I'm like, oh my God, I haven't had a headache for 2 years. Dr. Hodges, wake up. And so this patient came in, this is crazy. She's been to neurologists at Mayo and all these big hospitals up in Jacksonville. CAT scans, MRI. You know what the treatment is for her, Dr. Hodges?
Yes.
Migraine medication, right? Now guess what? She still has the migraines, even though she's on the medication. So what's the treatment plan? Continue the medication. Right? So she's out of school, can't do anything on this medication. They come in the office. I take the x-ray. The occiput in the C1 line should be parallel, right? Everybody see that? They're converging in the posterior. She's got a complete reversal of the cervical curve, anterior head translation. So I see this, I'm like, I think we can help you. Now, in the medical world, they take that x-ray, they're worried about cancer, tumors. Like, they might comment that she has a cervical kyphosis, but they're not gonna really do anything about it. They probably won't even put it in the report. Her follow-up x-ray after less than 2 months of care, the occiput and C1 are now parallel. She's reduced the forward head translation. She has cervical lordosis now. She has no more headaches. She's off the migraine medication, and she's back in school. If she would have never came into the office, she would have just been known as the migraine patient. And that's not acceptable, right? Wake up. All right. Hooter-Volkmann principle. Everybody getting a grasp of what's happening with that? So the bone is basically stopping growing here and expanding here. And you end up with this asymmetrical bone shape that reinforces the scoliosis. Once that locks in with your hormones, it's not correctable. And then we do a bending x-ray, so you can compare the bending to the neutral. You still may be able to reduce the curve down, but it's just not gonna ever be a normal curve. So like if a patient comes into our office and they have a 50-degree scoliosis, we're not gonna tell them you're not gonna have scoliosis, but we may have a goal of reducing that curve down by 30%. And then this is talking more about the developmental aspect of the brace. We have a unique opportunity to reduce the curve prior to puberty. With clear protocols in Scoli brace, these two cases gained almost 1 inch in height in 3.5 months, 2 inches of height in 2 years, while reducing the scoliosis curve. This is an example of using the Hooter-Volkmann principle to the patient's benefit. So this patient gained a significant amount of height, age 13, 15. She was very compliant with the brace, and the 41-degree curve reduced down to 21 degrees. You can still see she has a significant amount of rotation. She became a non-compliant patient, didn't wear a brace, do any exercises for 2 years. Came in, x-ray looked exactly the same, 21/21. And we found that, you don't want to tell people this, but we found that the corrections hold pretty good that we did. But we'd rather them keep up with their home exercises and recommendations. So Layla had a 22 reduction. You can see on her initial x-ray, she had the 34-degree rotation down to 12, 10 down to 2, 17 to 7. And that was using the brace. Josiah, 27 to 11, 20 to 10. In summary, adolescent idiopathic scoliosis, a multifactorial cascade concept for pathogenous and embryogenic origin, appears to be the model for causation and treatment. Epigenetics, family history, health, lifestyle of the mother, birth trauma, upper cervical instability, poor posture, lateral lordosis, loss of lumbar lordosis, loss of thoracic kyphosis, cerebral hemisphericity, disc pressure, muscle imbalance on EMG, hormones, low muscle mass, pseudovocal principle are all factors in developing scoliosis. So what causes scoliosis? You guys feel comfortable with answering that? Who feels comfortable? Likewise, a healthy mother, pregnancy, birth, development of the lateral lordosis, thoracic kyphosis, lumbar lordosis, optimal posture, balanced cerebrum, balanced, developed spinal muscle mass, help to withstand the coming storm of potential progressive scoliosis. So if you have a sibling that shows some indications, they can work on all those things preventatively. You don't have to wait till they have a scoliosis. Scoliosis success. I use that timeline all the time with every patient. It's in our orientation. It's at the front desk. We have people sign it. Because if the patients have an expectation of what the lifetime of a scoliosis looks like, they're not going to be upset or have any surprises. It's very important. Now with scoliosis, you do have a medical legal obligation for the patient. So if their curve is getting worse, you need to document, talk to them, and refer out either to a chiropractic scoliosis specialist or to like a children's hospital. Avoid adjusting areas of ligament instability. We talked about the alar ligament. Do I need to put the pantyhose back on, or you guys got it, right? You get the rupture here. C2 goes this way, C1 goes this way. I'm not going to be adjusting Gonstead chair on C1 from the left. The ligament damage is already taking it that way, right? Now, will I get a big pop and I do setup in my practical class? And like, everybody wants to adjust this one person. It's like, that's not an adjustment. That's just damaged ligaments. It's making noises. Avoid PDA adjusting in the thoracic spine once they have a greater than 10-degree Cobb angle. Monitor frequently with scoliometer and 3 to 6 month x-rays. If you have a progressing curve, I'm not going to wait 6 months to take an x-ray. You need to find out, is this curve getting worse or is it getting better? Document and educate, take action sooner than later. There's a whole group of patients that are looking for proactive results. When the pediatrician spots anything or the school screening sees anything as far as a rib arch, take an x-ray. Because if it's already showing up on there, there's probably a curve. A lot of times they'll say, well, let's wait till next year and look at it again and see if it got worse. No, this is like, you have an opportunity to correct it, and now you're missing out on that. Referral of progression. BJ Palmer said it's an inside out job. So when we look at scoliosis, who doesn't have one of these yet? Anybody else? Who else? So with scoliosis, we're always thinking about the upper cervical spine. It's coming from instability in the upper cervical spine, occiput C1, C2. This is one of the quotes Wogan would tell at almost every seminar. Nothing in the world can take the place of persistence. Talent will not. Nothing is more common than unsuccessful men with talent. Genius will not. Unrewarded genius is almost a proverb. Education will not. The world is full of educated derelicts. Calvin Coolidge. October 18th, over at the Celebration Family Chiropractic, we're having a Clear Advanced Seminar. It's $50 for students to attend. It is a great experience to see a scoliosis office and be around some successful doctors. It's a very great way to learn about things. So it's a Friday afternoon, Saturday all day. Some students, depending on what's happening in school, may only come Saturday, but typically we get a lot of people from the CVP club to come. So if you know anybody in that club, you can ask them about it. They're probably familiar with it. And Celebration is maybe an hour. It's like around Disney, around that area. We also have a virtual class in Clear now. It's 30 hours. All the Clear doctors had to retake the course. We lost our curriculum in flash drive. Anybody know about stuff like that? So like there was an outdated flash drive version, and a lot of continuing education was on that version of flash drive, and it was no longer supported. So we had to recreate the entire curriculum, and so that's been released now. And I think students can take this. I think for doctors it's like $900, but I think students it's like $150. It says it's a 30-hour course, but it's not a 30-hour course. So the standard with continuing education online now is you take a module, then you take a test. You have to get a certain grade to go on to the next module, right? So if you think about all the things that I just talked about, and then that's just a mere fraction, it's gonna take you a lot longer than 30 hours to go through this. But the value for what you're getting is unbelievable. It's a great education. It takes you through the Pettibon technique manual, just a lot of things from different perspectives. I highly recommend it. Now, I have to warn you something about technique. Your national boards in graduating from Palmer is like a finite amount of material. So I found like learning about chiropractic neurology and Pettibon and CVP, those things can work against you when you're taking some of these exams. So you have to realize that there's different perspectives, but then there's the perspective that's the high side of the rainbow when you take national board, right? So you guys know when you have a patient, are you gonna adjust on the high side of the rainbow? What? Are you gonna adjust the high side of the rainbow on a scoliosis patient? No, okay. But if you get the national board question, all right, who hasn't got one of these? If you have a national board exam and it says, if you have a national board exam and it says it's a scoliosis patient, how are you going to adjust them? And one of the answers is the high side of the rainbow. You're going to pick that, even though you know it's wrong, right? So it's like when you learn these different techniques, your check for a Thompson technique may be just the opposite and a different technique. But you know Palmer and the national board is going with what Thompson says.
Why if it's
You better put that as the answer.
Why if it's incorrect? There's not a push to
There's just different theories out there. But you're going to be tested on the mainstream theory. So if you learn a different technique that's not part of national boards, like Pettibon or CVP, you better answer with the mainstream technique. Even though the answer, you may not practice that way when you practice, but you got to get through these exams. All right, so do I have any more of these atlases? Does anybody need any pantyhose? I found this. Before I finish, Dr. Wogan loved this thing. People that are into scoliosis or subluxation reduction, they are wacky, Dr. Hodges. I mean, they will wake up, this guy wakes up in the middle of the night. He sends me emails at like 3 o'clock in the morning. It's like, dude, go to sleep. I mean, I wake up early, but this guy is like, he wakes up earlier than anybody I know. So, Dr. Wogan, these old-time chiropractors, they're just crazy. So, he would be like walking around in a hardware store, and he would see something, and he's like, oh my God, I'm taking that to the seminar. So, I don't have one of these for everybody. This is one he gave me. But when we look at Pedibond, this is like your A to P Nasium optimal spinal model, right? When we have the head tipped on top of C1, that is called the upper angle, okay? We want to reduce these acute angles. If we have an acute angle between the upper cervical spine and C1, that's called the lower angle. We want those to be reduced. If we have a compensatory angle here, it's C5, we call that the cervical dorsal angle. If it's an acute angle here, we want that reduced. And then the next one down is what's called the upper dorsal angle. So Pedibond basically is saying these are subluxations, and we want to reduce those subluxations. So it utilizes something called the righting reflex, meaning your body innately wants to right itself. So if you're like this, the eyes want to be level like this, right? But if you adjust somebody and reduce this misalignment, the head will come back and right itself. And if you don't have a bunch of neurological memory and spinal and ligamentous creep, the whole subluxation may disappear just from that one adjustment. So we do that adjustment, the body rights itself, and then everything corrects. And that's what innate intelligence is. That's these younger kids that don't have a lot of memory in their spine, and these subluxations are coming and going, and that's what health is, where you're not stuck in a pattern. And then as you get older, if you have traumas happen to you, and you get stuck in these patterns, that's what loss of health is, and that's what BJ talked about, patterning. So, feel free to contact me if you guys want to shadow and see what we're doing at the office. We also accept preceptors from Palmer, and I also speak at other clubs. And I might, I had this presentation labeled wrong. It said active care class, but I may come back for your class, for active care class, and we'll talk about more specific treatment things. And I think that's it. Anybody have any questions?
So you said to avoid E to A adjusting, so how would you recommend adjusting the scoliosis patient?
So if you have the patient like this, your hand is like this, and where those segments went anterior, you're getting them to drop in between your fingers here and your pisiform. So it's like going like that. And that's a Pedibond anterior adjustment. And that's how we would recommend it. We also, with the ArthurStem, on campus it's not certified, where they can use it in clinic, but there's a special blade on the ArthurStem, and what we do is we come on the outside of the rib cage with this flat blade. It kind of looks like the muscle working instrument, you know what I'm talking about, on the ArthurStem? It's got like a muscle blade. It's like a piece of rubber like this. You can do a lot of muscle work with it. But we take that and line it up on the ribs on the outside of the cob angle and adjust it that way. So we're still adjusting the thoracic spine, but we're not putting the downward pressure. We're using like the rib as a lever arm. Any other questions? All right, thank you guys. I'll see you at the active care class, I guess. Good work.
See you Monday, you all.